What's something in the last just 10 years maybe that surprised you most about discoveries in cardiometabolic health or hormone health?
That's a really good question. I would say it would have to be the inability to predict who has severe heart disease and who doesn't. Often, and maybe through my own hubris and others, you would see an individual and you go, wow, they look really fit. For example, I'd have a 60-year-old man come into the office and he would be jacked. He looked like he could run through the wall. And then I'd have a morbidly obese man and you would run the labs and you would expect that the morbidly obese man would be inflamed, inflammatory markers through the roof. And the skinny guy would be super fit and his labs would be great. Quite oftentimes, you can't tell by looking at people. You would get to the laboratory and go, holy smokes, this fit guy's inflamed and the morbidly obese guy isn't, and he's pre-diabetic and he isn't. And then we do a CT angiogram and take a look, and the super fit guy's got disease all over the place, and the morbidly obese guy who eats pizza on an everyday basis doesn't. No evidence of disease, no inflammation. That would always leave me scratching my head. How can that be? It didn't fit what you're seeing, right? The visual representation. Over the years, I've come to the conclusion, if you're not testing, you're guessing for sure. You can't tell by looking at people, especially when it comes to cardiometabolic disease, because it's a slow burning fuse. You can't see it, you can't feel it. And the first symptom of disease is usually the event itself, the heart attack, the stroke. So just all of a sudden one day you're fine and then bam, the next minute you're not. So what can you do from the longevity standpoint and hormones? If you look at the risk factors for both men and women, men over the age of 40, women that are post-menopausal, their greatest risk is from a major adverse cardiovascular event, so a heart attack or stroke. Men will always think, oh, it's going to be cancer. Women, it's always, oh, it's breast cancer. No, it isn't. If you look at the data, men over the age of 40, a heart attack, stroke. Women that are post-menopausal, heart attack and stroke. Premenopausal, the data is very different. It's 1 in like 32 women. Postmenopausal, it's 1 in 2.8. Holy smokes, what a change.
Yeah.
To go from that number to that number. So when we're talking with respect to longevity, my focus has always been, this is the number one thing that's going to get you. So what can we do to mitigate your risk? Looking at it from a 10-week perspective, a 10-month perspective, a 10-year perspective. What is your threat in that window? And then what can we do to mitigate that risk?
One of the most surprising things to me as well, working as long as I have, and then when we look at the labs, when I go from the bodybuilder and look at their labs to the average weekend warrior in the gym who still likes to drink heavy and eat heavy, I would always be surprised by the variety of labs you would come back and you thought the eye test is just not good enough anymore. You need to test, don't guess, especially today, as I've done about 55,000 histories and try to get some correlative information that we can use. And I feel like personally, there is a peak amount of muscle before the size of the individual starts hurting their cardiometabolic health. Granted, you still should test, but what I've noticed is my guys that are very mesomorphic, let's say they're at even a 12 or 15% body fat, but they've got an extraordinary amount of muscle mass, even if some of it's genetic. Because you see it with female athletes too. If you go in your yearbook and you look at the best female athletes that you had back in the day and then go look them up on Facebook now, they're all way overweight, they're very unhealthy. And so the correlation that I have made is that the more of a genetic athlete you are when you're younger, if you don't keep in that environment, you were built to be a racehorse. If you don't continue to be a racehorse, you are not as genetically successful in the high calorie, low activity environment. One of the things we know for sure is that with more muscle, you're pumping more glucose into the blood vessels as a product of feeding. That extra glucose can be good for activity. But if that extra glucose kind of just stays there, even though you've got more muscle, you can become glucose insensitive. When you look at cardiometabolic issues, before you get to cholesterol, I think the strike that could cause the fire in the vascular system is really glucose. And I could be wrong, but I feel like when you look at the relationship between
I don't think you're wrong.
Yeah, what do you think about that?
Insulin resistance. When it comes to lipids, there's only a couple levers that you can pull to manipulate lipids. One is nutrition, the other one's pharmacology. So an individual who's athletic and then slows down, you don't want to slow down. You need to keep moving. As soon as you stop moving, death really starts. So regardless of your age, 30, 40s, 50s, 60s, you have to keep moving. You cannot stop. That just accelerates the decline in your health and wellness. So you always have to keep moving. But back to your point with the sugar, it's carbohydrates and sugars that the overconsumption and sedentary lifestyle leads to an acceleration of disease. So if you can limit that starchy carbohydrate intake, sugar intake, and keep your activity level up, you can do the best for your overall health and wellness. Then there's going to be genetic factors that come into play. Do you have all 4 obesity genes? You've got some issue where you just can't consume sugar because of your genetic history. You do better on a protein forward diet, where there's other individuals that can consume carbohydrates with nary an issue and just continue to lose weight. Another person, they look at a potato and they put on 5 pounds,
Yeah.
you know? So, and that always comes back to individual genetics.
Yeah.
And you do need as an individual to eat in that appropriate fashion for you.
Yeah.
I always personally do better with a protein forward diet, lots of root vegetables, and I limit starchy carbs, the rices, the breads, the pastas. I can have them, but I shouldn't be eating them at every meal.
Yeah.
Having them a couple times a week, no big deal. Preloading or afterloading from exercise with those types of food sources, that's fine too. But the overconsumption,
Yeah.
this is a bigger problem for society in general. There's 24/7 food access, it's carbohydrates, the sugars, all of that, and never giving you a chance to give your body a break, taking a day just to fast. I like to fast on Sundays, along with just it being religious. So
Yes.
Saturday evening to Sunday evening, I like to do a 24-hour fast, and I'm pretty dedicated to it. I think some people overdo it, but
I think you're nailing it on the head.
the overconsumption of sugar in our current society, the way the food sources, the processed foods, the chips, the cookies, the candies, the cakes, I see the excessive overconsumption. But then I see the other side of the coin where people just going overboard and not enjoying some things when it's okay to have some of those things on an occasional basis.
One of the interesting things is there's been plenty of studies on bulimia and anorexia, and they show very high levels of blood glucose. It's interesting how in the bell curve, if you overconsume, you'll look very similar in your blood sugars as if you underconsume, which I always thought pretty fascinating.
You want to be statistical mean, right? When we look at that probability curve, you don't want to be far right and you don't want to be far left. You want to be at the mean.
This is a great message for everybody out there. To all my bodybuilders or people who have been very focused on protein and muscle mass, that doesn't insulate you, especially if you've been pushing a lot of carbs to keep that size. As Dr. Rob was saying, based on certain genes, and we test them at Vital Coaching, I look at your ATG genes, I look at PPAR, SIRT1, TFAM, and these genes a lot of times will tell us a lot about your ability to have cellular cleanup from glycolic end products. So again, if you're pushing a lot of mTOR and muscle all the time, you're going to have a lot of what are called glycolic end products, and your body's got to clean those out, and it uses the AMPK pathway to do that. So if we're pushing carbs, pushing training all the time, I get a lot of guys that are super fit and they come in and we look at their labs and they look absolutely terrible. And it's because they haven't used diet variation. They haven't rotated. They haven't introduced any fasting, or they haven't taken the carbs out or done enough caloric restriction to reset their metabolic cycle. Learning about those genes should be more of your general preset style of diet, just like Dr. Rob was talking about. A lot of that stuff you can figure out through genetics and then also through some of your own lifestyle trial and error, right? So it was really fascinating that you said that.
Then pharmacology, especially bodybuilders, from a pharmacologic standpoint, are using chemotherapeutic agents.
Yes, let's talk about that.
And those chemotherapeutic agents were never meant for how they're using them.
Anti-estrogens.
And they have a lot of negative impact on the cardiovascular system, the neurovascular system, bone and mineral metabolism. And it's a very powerful medication, for example, anastrozole. And while it does have utility, it needs to be used strategically. We use that chemotherapeutic agent for women with breast cancer.
Yeah,
And they're on it for
as you go into this.
We're on that for like 5 years. Right?
Yeah, you're right. Can we sum this up real quick for the listeners so that way as we go into this, I think they have a pre-frame. I'd like the pre-frame to be what you eloquently said earlier. You made a statement about once a female goes into menopause, her rate for heart attack goes up 2.5-fold, right?
Well, it goes from 1 in 32 to 1 in 2.8.
It's insane.
They lose the beneficial protection of 17 beta estradiol because of ovarian failure. Estradiol is converted into estrogen-free fatty acids in the liver. Those free fatty acids are what keep the matrix metalloproteinases in check, in particular MMP9. So if you have plaque, it's the MMP9 that one of the enzymes that degrades that plaque while allows for rupture.
Whoa.
So that's why the heart attack and stroke rate risk for women is much lower premenopausal, perimenopausal than postmenopausal. So then you take that medication and give it to a bodybuilder who's using it for aesthetic reasons to control estrogen because they're taking insane amounts of steroids.
Yeah.
But that medication's incredibly powerful. And now you're losing the beneficial protection of the estrogen from a cardiovascular, neurovascular standpoint and a bone and mineral metabolism standpoint. I often see these patients that have been on that medication for just a year. We'll put them on the DEXA scan. They got bones like an 80-year-old woman. Their hips are terrible. Their spine's terrible. And I'm like, why don't we do a CT angiogram, take a look at your heart vessels and see what's going on? And you'd be amazed if somebody's in their 30s and they see disease, like significant disease. And then I'm like, wow, we'll probably take a deeper dive into your lipids, get a better understanding where you're at, because we only have a couple levers to pull here to try and eradicate disease, minimize disease, or even regress disease, which we can do with some of the pharmacology that we have available to us now. So it's really interesting to go down that whole pipeline. What can we do to regress disease? Because if we're speaking from a longevity standpoint and being 60 years old, I'm thinking, geez, I don't have a lot of runway in front of me. So how do I make that runway longer? And how do I make sure that on that curve, I don't want to just dive into, because for most people, the last 10, 15, 20 years is full of disability and problems and chronic disease. So how do we rectangularize that graph so we can kind of keep going like this as long as we possibly can go? I would argue, coming back to estrogen, that it's equally important for men as well. Women need it incredibly so. And why do we see the acceleration of disease in women when they go into menopause? What do they lose? They're losing the beneficial protection of estrogen and progesterone.
And you're saying that men lose that too then when they use too many anti-estrogens, or they're using Anavar or other substances in too high amounts that cuts off aromatase. So men with lower estrogen levels too. This has been a big change. I remember in bodybuilding and fitness in general, it was like, get your estrogen as low as possible and test high as possible. And now we're beginning to realize that was a huge mistake.
There was a study, I can't remember what year it was, when they looked at the use of anastrozole to raise testosterone level in men. And it works. It raises testosterone levels. But they never looked at the bad side of what are all these things that it does. It's like, okay, well, you're going to have weak, brittle bones. You're going to increase your risk of cardiovascular disease and neurovascular disease, but you'll look better. So it depends what your perspective is. If your window is like this, I'm competing in this competition and I want to look like X, Y, or Z, and I'm going to do this. But then if you turn it into a lifestyle, that's something completely different. And so when the two crossroads of hormone optimization versus bodybuilding, they're separate. They really don't cross at all. And there's been this mix of spilling over into longevity. It doesn't work. It has negative impact from a cardiovascular standpoint.
Well, actually, there's been a big change too in fitness in general, outside of just, let's just say, the narrow field of bodybuilding, although it helps us look at hormones from an interesting way.
It does. I mean, going back to the 90s, that's how I got my start in hormones. It wasn't for some particular bodybuilders. You know the story of the kid on the motorcycle. Right? And I couldn't find answers to anything. And then I went and rapped on the door of a bodybuilder and said, how do you take this and not feel bad? He was kind enough. He had this protein powder shake and he unscrewed it and pulled his sheet out and shook it off. He's like, this is what I do, doc. And when I looked at it, I was like, wow, he takes 200 milligrams of test Monday, Wednesday, Friday. I'm like, that's crazy. But it clued me into thinking about the pharmacodynamics and kinetics of this medication. And maybe that's the answer to getting this young man feeling better. And then we started microdosing. We didn't call it. That's what we did. It's like, let me cut it down to maybe 20 milligrams Monday, Wednesday, Friday and see how he feels. Because the textbooks back then, it was 200 milligrams every 2 weeks.
Yeah. Nothing.
I feel good. I feel bad. I feel good. I feel bad. That
Yes.
sounds like a terrible way to live to me. I wouldn't want to live like that.
So what we're
Mhm.
talking about here is how the black market bodybuilding fitness community, the unpublished clinical evidence has bled into how science and longevity and vitality clinics have changed the way they use certain products, hormones, peptides. Over time, those two have
Meshed a little bit and then you're tangled.
Yeah.
And some of the bad stuff is spilled out. It's like, you got to get that.
Yes,
That
yeah,
really
yeah.
doesn't belong there. But
Yeah.
yeah,
But that's like, but the hormones has been a world of trial and error, and the fitness world has done a lot of that for us.
I'm very grateful to the fitness world and bodybuilders because back in the day, here's this huge cohort of guinea pigs taking
Yes.
obscene amounts of steroids. And,
Yes.
and then, over time, the realization is like, hey, it's not the steroids that are a problem. It's some of the subordinate medications that are being used in the background that are actually causing problems.
There has been a big change. Even when I am in the groups of the best fitness coaches or bodybuilding coaches and in my own health journey, we're figuring out that you don't need to get estrogen that low to be lean. We thought it's one of those things where you get confirmation bias. And what you think you're looking at, it's like if we zero estrogen, you get tighter. Well, you're probably moving water, which is true, but you're also gassing yourself out. I mean, there's a lot of other side effects. Right now, like for example, for me, I don't mind my estradiol. I'm on about 120 milligrams of testosterone. I divide it out about 3 times over the week. I watch my estradiol. I let it get a little bit above the high rate, like what's considered high in the labs, so things like 54.
Depends which lab you're using, but I like the ratio to be about 6 to 8% of your total testosterone. That's what normal looks like, 6 to 8%. You'll have some individuals that are high aromatizers and other ones that are lower aromatizers.
Yeah, we see that in genetics. You can
Right,
figure
it's
that out.
genetics. So
The CYP gene.
if you get your genetic testing done, you'll be able to see what kind of an aromatizer you are. Just looking at the labs, most people are 6 to 8%. I had a fellow the other day, it was about 4%, which was crazy.
I'll have to go back and calculate because I'm sitting around 800 test. So 8%, puts me about the right spot. Because I feel my best. Do I feel the difference between maybe like a 47 and a 54? Probably not.
Most likely not. Some people, if you're lean, you're going to feel it in your abdomen. That's where you're going to pick it up,
Yes,
right? Because you're going to feel the bloat there. That's generally where you're going to see it.
You think it's beta glucuronidase that's doing
Yeah,
it?
a little bit. So, bloat. If you're a woman and you have excess estrogen, the bleeding, breakouts, breast tenderness, mood instability. Those are all symptoms of higher estrogen levels. And if you're a leaner guy, you're going to feel that excess water, feel it.
I'll be honest with you, since I've decided not to suppress my estrogen, my skin, my hair, my age,
Feels better.
Everything feels better, looks better. I think we made a big error. And it's kind of coming to fruition because now everyone's warning on anastrozole and letrozole.
We've been talking about it for over a decade.
Yeah, you've been talking about it a long time.
Lecturing.
Everyone was afraid of the testosterone, but now FDA takes away the black box warning and everyone's realizing it may have been that we were crushing our estrogen to zero.
Supporting cast of medications that were being used that are really problematic. Testosterone in and of itself. There'll always be individuals that are going to have unwanted side effects from any medication that you'll have to deal with. And testosterone is no exception. But being made the villain for as many years as it had been, it's good to have some vindication because in the 90s when I was prescribing testosterone, the slanted looks I would get from people, and then going through the early 2000s and then the attack in the mid-teens. And then finally some vindication now. It's like, hey, all the things that we were seeing clinically and what we were experiencing, what other studies had shown, in particular with aged men who've had previous heart attacks or strokes, how beneficial testosterone is. My opinion, every cardiologist should be an expert at the use of testosterone because it's so important for cardiovascular health, for neurovascular health. Testosterone causes heart attacks and strokes. Thank God we got past all that. If that was something I had seen clinically in 30 years of delivering testosterone therapy, the heart attack and stroke rate risk in my patient population is actually lower than the general population.
That's what they're seeing in some of the studies now too.
Right. So it's like, I would have stopped giving testosterone years ago if people were dropping dead from heart attacks and strokes. Just wasn't the case, wasn't seeing it. And those manipulated studies that were finally done away with.
Yes. I think there's a good lesson in that, everybody, what he just said. You've got an expert who's watching it day in and day out as a tool. One of the things that I like to do is when I see research that tends to conflict with what I think I see as a behavior or a belief, I go to the practitioner that's using it a lot, that is a trusted source, find them online and watch them for a while, because they're on the ground floor using it every day. They're going to know exactly how that's affecting. And I trust that person, especially if they're working on my population, my demographic. I'm going to trust that person over what some literature says that's looking at large population studies, because that's going to give me an idea of what's really happening, the difference between clinical evidence and practitioners' field versus just bulk data.
You've seen it. I mean, back in the day when you were in my office, you would say patients that came in and then we'd get them on therapy, and literally in 6 months, they'd look like different individuals. It was astounding. And there's so many of those instances that I've had over the years. Every month, I see these complete changes in an individual. And the data reflects that. It's amazing to me that some of the data people ignore, especially, for example, the Intermountain studies with respect to older men that have had previous heart attacks and strokes. What do we see? They're in the upper quartile of therapy. They live longer and they do better. Flat. The data shows it. If they're on medium dose, their heart attack and stroke rate risk is a little higher. If they're not on testosterone, they're in the highest heart attack and stroke rate.
Yeah, that's right.
Group. Those individuals will do much better on therapy than off therapy. And if they're not having any intolerable side effects, they should be on it. Does that mean everybody should be on it? No, there's always going to be some people that can't tolerate it. I'm 60 years old, naturally kicking out high levels, 900, 1,000 with a free of around 20.
Are you supporting that with either HCG or Clomid or
No,
like that?
just supplementation, healthy eating. There's a foundation to health. Being healthy, influencers always want to push the next greatest thing that they can sell, but sleep, regenerative, recuperative, restorative sleep, meaningful exercise, restorative practices, prayer, meditation, Tai Chi, yoga, whatever your thing is for stress reduction, annual diagnostics, nutrition and rotating nutrition, epigenetics, hormones and supplements. Those are the levers that we can pull. None of that is exciting. It's stuff that needs to be done consistently on a daily basis. You need to get some exercise. You need to have restorative, recuperative, regenerative sleep. You need to rotate your nutrition. Most people eat the same 7 to 9 foods their entire life.
Yes.
Well, how about let's rotate your proteins? Let's rotate your vegetables.
This is dangerous.
They get in the habit of just, and you really need to focus on rotating your food and meaningful exercise depending on where you're at. Like, so in the 6th decade, I want to maintain as much muscle mass as possible, because you need to be able to get your butt out of a chair unassisted. You need that 1.4 Newton kilograms of force to overcome gravity. Otherwise, you're going to end up in an extended care facility. What's ahead for me in the 7th decade and 8th decade? I see what's happening to my parents. Dad's 89, mom's 84. I don't want that. I don't want my 7th and 8th decade to look like. I want to be mobile. I want to be strong. I want to be free. I don't want to be isolated and bound to a house or a chair. Doing the things that make a difference, sleep, exercise, restorative practices, nutrition, doing your diagnostics, getting the right diagnostics. Many people get laboratory, for example, that's just, it's so superficial. They get a CBC with a Chem 7 and a urinalysis, and they go, oh, okay, the CBC, I want a Chem 21. I want testing done. I want a DEXA scan. I want a carotid ultrasound. I want a coronary CT angiogram. I want intense lipid studies.
What a carotid ultrasound is?
Yeah, so an ultrasound where you can take a look at the carotid arteries and look for evidence of disease.
Mm-hmm.
So one of the first places that we're going to see disease is at the bifurcation of the carotid arteries. Why? Because when it splits off, the way the blood flows and fluid dynamics, that's where you'll see disease first.
Same thing. I get a lot of vessels.
Just because you can see your neck doesn't mean. But we did a CT angiogram on of your coronary arteries, and where the disease generally shows in the left anterior descending and some of the other branches, it's very predictable. We go and look in those places so we can decide, hey, what's your 10-week risk, 10-month risk, 10-year risk? So we can look at that. And we did intense lipids on you as well. It's like, hey, these are your health threats. So what can we do to mitigate these threats so that we can have a long, healthy life? Because what's going to get you, and you don't think about it when you're 40s, heart attacks and strokes, like, that's for old people. Well, 40, you're middle-aged.
Yeah.
It's hard to think of it that
I
way.
know.
I look at pictures of my dad when he was 60 and I'm like, "Phew, I hope I don't look like
No.
that," right?
You're killing it. So would you say if someone were to take away, if they're like, okay, so what I'm hearing is that testosterone lowers my cardiovascular disease risk and helps hold my body composition so I don't lose it through sarcopenia and that kind
Yeah,
of thing.
is testosterone good for the heart? Yes. Is the overuse of testosterone or excessive
Right.
dose? No, just like any other medication. You can take too low a dose, you can take too much of a dose. There is that happy medium of somewhere that you want to live. Pushing the envelope and taking excessive amounts of anabolic steroids for a long period of time is not going to be good for your overall health and wellness and
Got
your
it.
longevity.
So like you said, the CT angiogram, how often should someone get that? Because that's actually a 3D scan of the actual artery itself.
So it's a coronary CT angiogram. And so the CT scanner, there's two parts to the test. They put you in the scanner, clickety, clickety, click, in about 10 seconds. They take a look at the arteries, and we're going to get a calcium score. Then they pull you out of the scanner. They run the dye back in the scanner, click, click, click. And then we get the second part of the test where we've run the dye. Now we can take a closer look at the artery. So you can have a CT calcium score or you can get the angiogram. What the difference is if you look at plaque, there's 8 stages of plaque. And 1 and 2 are fairly reversible. 3, 4, 5, and 6 is the really bad stuff. 7 and 8, it's calcified. So your CT calcium score only identifies calcified plaque, but it's 4, 5, and 6 is the dangerous stuff. The stuff that, is fibrofatty, necrotic that you're not going to see because it's not calcified yet. We can extrapolate that if you've had a CT calcium score and you've got a heavy burden, there's a lot of disease there. But it can give you a false sense of security. I've seen patients where it's like their CT calcium score is negative, but we do the angiogram and they've got 4, 5, and 6 plaque. It's not calcified yet, but they've got fibrofatty plaque in specific areas and even some necrotic plaque. That's the quiet threat in the background that you don't know that's there because you can't feel it, you can't see it till the event actually happens.
Right, because there's probably a lot more of that plaque building up on the calcified.
Well, it's more running through a stage. So you've got
Okay.
1 through 8, like on that spectrum, right? So 1's just starting. And you can see disease in very, very young people, even in children. When I had I did one a year ago, 0, 0, 0 calcified, 0 soft plaque. That's the goal, a 0, 0 score. Like when we did yours, you had a little bit of calcified plaque. And, what's interesting, so how is it that I'm 60 and you're
just
40 and we have evidence of disease? So we took a deep dive into your lipids, and what do we find? Well, you have a lot more ApoB, and then you also had some lipoprotein little a,
little bit.
right? So the heart attack cholesterol, which is actually classified as a thrombophilic disease, right? There's a whole group of the thrombophilia hypofibrilltic disorders, which can lead to a higher heart attack and stroke risk. So it's like, well, how did Vince have disease, but then I'm 20 years older and don't? So why is that? And when you look at the lipids, maybe sometimes the answer is there, right? Sometimes it isn't.
I tend to think, and this is where I do want to go, the more that I look at like LDL and all-cause mortality, and you look at the relationships, it really appears to me that LDL is actually the immune mediator inside the cardiovascular system. By assessing risk factors, we can look at all the different ApoBs, VLDL, your LP little a, all of the different ones. But as I begin to explore further, it would appear to me, especially like when a female goes into menopause, we see that her immune system goes haywire. It causes more immunosuppression in certain areas, requiring our T cells or T lymphocytes to overcompensate, which are very pro-inflammatory. And then it appears LDL begins to rise. We see this. And estrogen appears to have, because there's more estrogen receptor sites on lymphocytes than there are androgens. And so what it appears to me is that at the intersection of the mitochondria, because it has such an impact on the immune system, total oxidative stress on the system, which is why a little bit of everything affects everything, right? Because everything affects the immune system, sleep, day, sunlight, isolation, like spinach,
stress, all of it.
It's the net total effect of all of these things that are almost somewhat unquantifiable without a supercomputer to talk about your total effect. But I feel that the answers will be found in the mitochondria, the DNA, and then also in the immune system and how we can try to manipulate LDL better with other levers. I'm hell bent on getting.
I don't know, lipids get a bad rap.
Agreed.
And I don't think they should. They're just doing their job.
Yeah, agreed.
Overconsumption of carbohydrates and sugars.
Yeah.
Leading to inflammation. Then there's genetics in the back. But if you're type 4 hyperlipidemic and your blood looks like milk, okay.
Yeah.
You've got a problem. That's what these medications were intended for. But the fact that so many people are just knee-jerk, put on these medications and saying, well, we need to lower everything. Statins in particular, which I have like a love-hate relationship with statins, because you're going to have individuals that end up with medication-induced hypogonadism because of pharmacotherapy. So they're on multiple medications that lower their hormones and has a negative impact on longevity from that standpoint.
And so what he's saying
Some people would argue that a statin improves longevity.
Right.
I would argue it actually does not. There are some individuals where their use might be justified, but the knee jerk where everybody's put on a beta blocker, a statin, and an aspirin, I don't agree with.
Yeah. In the pursuit of getting your cholesterol down, you're going to ruin your sex hormones.
The trillions of cells that make up Vince and the trillions of cells that will be Vince in the next 24 hours are all that bilipid layer is made from cholesterol. Your brain is cholesterol. Every hormone is cholesterol. So you can't live without this, right? You're literally a blob of cholesterol and vitamins and minerals floating around in the universe. You can't wipe out cholesterol. The fact that they want to vilify it constantly.
Yes.
I get patients all the time. The reason why they feel so bad is because they're having lipids manipulated not in a good way. And the obscene doses of them. This has been looked at, the efficacy of statins in particular. Once you get over 10 milligrams, the benefit just drops.
Yes.
But now all the side effects just magnify.
Yeah.
And we have problems, you're on it long enough, you're going to end up insulin resistant diabetic, you're going to have sexual problems, thyroid problems, weight problems, apathies, neuropathies. These medications are not benign. And
the dark side of statins.
oh yeah, the dark,
shared that.
Yeah, the very dark side.
What do you think about, because this is fascinating, because I'm hell bent on getting my LP little a in check.
Listen, just because you have LP little a doesn't mean that the book is written.
I get it.
Because I get plenty of patients that everything will be skewed. When we look at all their testing, it's like, hey, everything looks good. Just because you have one parameter that's out of whack doesn't mean bad things are going to happen. You can have lipoprotein little a, for example, and never have an issue, never end up with aortic stenosis, never have a heart attack or stroke. You could have pattern A where everything is just beautiful and you have no insulin resistance or anything and still have a heart attack.
Yep.
So I've seen plenty of people with pattern B cholesterols, lipoprotein little a's through the roof, ApoBs through the roof, and we do their CT angiogram, everything's fine. They've never had a heart attack or stroke. Then I get a patient in the office. They're pattern A, there's no inflammation, there's just nothing, but they had a heart attack.
Yeah.
Littered with disease.
Yeah.
Well, why is that? That doesn't make any sense. That's the conundrum. You can't tell by looking at people. You really have to test.
Amen, brother.
Because otherwise you're just not going to know.
I am obsessed looking at B vitamin science and nicotinic acid and its relationship in higher dose. So there's no studies on high dose nicotinic acid.
Yeah.
So I'm currently guinea pigging myself.
I've never done that. Ever. Yeah.
So there is data using a product, a selective kinase response modulator called Caprex, small data. It's a couple people. And they were able to do incredible things when they combined niacin and the Caprex together. It's also an NF-kappa B inhibitor, right? I'm playing with these detox programs where you could get up into, you peak it, like you would stair step.
What are we detoxing?
Yeah.
What are you detoxing in particular?
Well, all cellular, just opening it up.
Okay.
But while I'm detoxing and I'm using all these nutrients and I'm pushing things through the liver, I'm thinking about mitochondria now. My new flush is a extended version where we pyramid nicotinic acid. Not nicotinamide, like the active flush version.
The non-flush doesn't do anything.
Even though in studies it talks about it, nicotinamide, it's the precursor to NAD, nicotinamide ribose. The NAD thing is a whole nother thing where I'm like, yeah, for some people in their genetics, it's
sure, as you get older, inflammation, infection, mitochondrial dysfunction, fatigue. The common complaint that I always get is if it's not hormonal, it's I'm tired all the time. Depending what their age is, and you look back at their history, infection, inflammation.
Amen. I see the exact same thing.
Yeah, mitochondrial dysfunction. You eliminate infection pretty quickly, and then depending on their laboratory, you'll pick up signs of inflammation. Then if there's nothing, it's like, okay, well, you're 60 and you're tired out. It's got to be mitochondrial dysfunction. So what can we do to improve mitochondrial
There you
health?
go. That's a great deductive process to get to when NAD is really useful instead of a 24-year-old spending their last dollar thinking that it's really
Right.
useful.
Yeah.
And you're using it for no reason.
You know, I like injectable. There are some liposomal products I like. Yeah. But the injectable NAD.
So now I'm experimenting with walking my nicotinic acid up to about 5,000 milligrams and then back down. I'm paying attention. This is not how you're supposed to do this. The reason is because I'm doing one variable decision making. I'm looking at nicotinic acid and a certain dose and focusing. Although I'm looking at all lipid parameters, I'm looking at LP little a, and it's too myopic, I know, but I'm having fun with it.
I've not seen it lower.
Really?
I've not seen anything that's been effective supplement-wise that's significantly lowering it. You can use bergamot, niacin, alpha-lipoic acid, and high-dose vitamin C if there's signs of inflammation, but nothing's really been effective. There is a medication that's in trial. I don't know if it's going to get there. I forget the name of it.
About the PSK9 inhibitors?
I've not seen them move it. I do like PSK9 inhibitors for regressive therapy, whether I'm using Repatha or inclisiran when I want to regress therapy. But I'm going to tell you the strongest medicine to regress therapy, testosterone for regression therapy. When I see disease, if I can optimize hormones, growth hormone, testosterone, DHEA, change their food sources up a little bit, I can sometimes avoid using some of these other medications. Oftentimes, though, my choice is going to be Repatha or inclisiran. I like the PCSK9 inhibitors. I like bempedoic acid. Generally stay away from statins. But I take a deep dive in lipids because one of the things I want to know is, are you an overproducer? Or are you an overabsorber? Cholesterol is so important for the body that, the body has a system to pull it all back in, the Niemann-Pick pathway. So your body wants to keep it. The liver makes it. You don't consume it. It's going to make the cholesterol. If you're an overabsorber, a medication like ezetimibe might be appropriate. If you have disease, if you're absence of disease, just because you're overabsorbing cholesterol and bile, because that pathway is efficient. And
what does overabsorption look like in labs?
And when you do your lipid panels like Boston Heart, you can take a closer look at the lipids, the pre-lipids, and see, are you an overproducer of pre-cholesterols, or are you an overabsorber, or are you both? Because it'll dictate which medication I'm going to use. So if you're an overabsorber, for example, statin, a PCSK9 inhibitor doesn't make a lot of sense. We'd want to use a medication like ezetimibe, which blocks absorption of cholesterol because you're an overabsorber.
Got it.
Right? Now, if you're an overproducer, we can look at different options. We don't necessarily have to use a statin. We could use bempedoic acid, which works on the production arm side of it, right? So we slow down production, but you get the interference that we have and the problems that we have with a statin. If I want to use some kind of regressive therapy, I see active disease. Now I'm looking more like at PCSK9, whether it's going to be inclisiran or Repatha. They work by a couple different mechanisms. But what I've found more often than not, reversing prediabetes, diabetes, and I'm not talking about juvenile diabetes or early adult onset. I'm talking about dietary diabetes, sedentary diabetes, right?
Yeah.
Testosterone works wonders. I often get men that they're 10, 11, 12 on their hemoglobin A1C. By the end of the year, we have them 5.2.
Wow. So using testosterone as an independent therapy against
lipid derangement, prediabetes, diabetes, insulin resistance. Testosterone is incredibly powerful. What's interesting is seeing this clinically over 30 years. The first one I started noticing it, back in the late 90s, early 2000s, I'm like, wow, his diabetes got better. Not that I saw a lot back in the 90s. I saw 1 or 2 new diabetics a week. To now, it's everybody that comes through the door.
Wow.
Which is crazy. I hardly ever saw new onset diabetes. To now, it's everybody. Literally, everybody comes through the door. The story is the same. They're in their 40s, their 50s. They sold their company. They've got all this money now. Yeah. And they've neglected their health. Now it's like, please, I don't want to have a heart attack or stroke, and I want to enjoy the fruits of my labor. But they didn't take care of themselves for 20 years. Yeah. Right? So they're all pre-diabetic, insulin resistant, high hemoglobin A1C, CRPs through the roof. And then if you tack on a few other metabolic abnormalities, like one of the thrombophilia hypofibrinolytic disorders, like lipoprotein little a, for example, or homocystinemia. So, which is, the genetic test,
Genetic
right?
has
So
been
coming
incredible.
and it's so simple to fix. It's
Yes.
oftentimes.
Doc, this is incredible. We're going to close on that testosterone point. I want people to close with one they can walk away with. If people want to hear more, or they are concerned about their cardiometabolic health and want to run through, how can they find you, or what would be the process?
Yeah, I'm easy to find. Renew Health. It's RENUE health.com. You can fill out forms that the staff have put online, or call the office and get appointments. We like to start with pretty intensive labs. We don't do cursory labs. We're going to take a deep dive. When we identify threats, then we're going to take an even deeper dive, and then we may recommend other testing. Because for me, it's let's identify your health threats, and then what can we do to mitigate those threats as you age?
Yes.
That's longevity medicine. The thought that there's this magic pill that's out there that's going to make it all go away. There is some magic pills: sleep, exercise, fasting. And I find that whole area interesting, like rapamycin and fasting. That you can replicate rapamycin with the fasting, but you don't want to go overboard. But all that
mTOR right now,
right?
yes.
Yeah. So, taking a break from food, all the levers you can pull to sleep, exercise, restorative practices, hormones, supplements, epigenetics. You only have to do that test once. And don't do the cursory one that looks at 4 different ones,
Yes,
right? Like, pay the money and get the big test done. You can really dial in your therapies and improve your
getting a full in-depth genetics panel, getting these tests done at least once can absolutely change your life. Doc, thank you so much for coming on today, and we'll probably have you back, man. I love just
I love it too.
Awesome.
It's good to see you. We go way back.
and longer to come. So, all right. Thank you, everybody.